you. We proceed with our second presenter, which is Aisyah binti Cik Rahimi. Please.
Assalamualaikum and a very good day to all. I am Dr. Aisyah Sheikh Rahimi from the Department of Psychiatry, School of Medical Sciences, University of Science Malaysia. My code will be is M32 with the title of Psychological Distress Among Malaysian University Students During COVID-19 Pandemic. Do religiosity and religious coping matter? Thank you.
Okay, thank you. I would like to call upon our third presenter, which is Roslina binti Muhammad Fazilah Mah, to give your introduction.
Hello, Assalamualaikum. Good morning. My name is Roslina binti Muhammad Fazilah Mah with the code M33, and the topic of my presentation is on the assessment of oral health knowledge, attitude and practice of caregivers of children with autism spectrum disorder. Thank you.
Okay, thank you. We proceed with our next presenter, which is Suhaila binti Mat Said.
Assalamualaikum and good morning. My name is Suhaila binti Mat Said. My code M36. My topic today, perception of recreating infected COVID-19 and associated factor among oral health worker in attending patient during COVID-19 pandemic in Malaysia. Thank you.
Okay, thank you. We proceed with our next presenter, which is Ruzawani binti Ruslan, to give your introduction.
Assalamualaikum and good morning to all.
Okay.
I am Major Dr. Ruzawani binti Ruslan, a postgraduate student of doctorate in dental public health. My title today will be the age and factors of smoking initiation among army personnel in Kelantan.
Okay, thank you. Next, our presenter is Vinovan Kunasagaran to give your introduction.
Thank you, Doctor. Very good morning to all. My participant codes will be M35. I'm Dr. Vinovan Kuna from School of Dental Public Health. And my research presentation today will be on oral health knowledge, attitude and practice among primary caregiver of visually impaired children at Hostel University of Science Malaysia. Thank you.
Okay, thank you. And last but not least, our last presenter, which is Muhammad Nazir bin Muhammad Nazari, to give your introduction. Excuse me, presenter Muhammad Nazir bin Muhammad Nazari, are you here?
Yes.
Okay.
Thank you.
Do you mind to give? Okay.
Okay. My name is Muhammad Nazir bin Muhammad Nazari, presenter code M47. My presentation entitled Health Efficacy and Assertiveness Scale in Malay Language, a Validation Study. Thank you.
Okay, thank you. Thank you all for your cooperation. You may now mute your microphone and switch off your camera. Please silence your mobile phone. You may now you may only turn on the microphone and camera during your Q&A session. Thank you. We will start the room now. Assalamualaikum and a very good morning to everyone. Welcome to the oral presentation for Room 7, Medicinal and Health Sciences Community Study. My name is Dr. Muhammad Shahirul Aiman, and I am your MC in charge for this room. Firstly, I would like to introduce to all the presenters and participants our judges for today, which are Dr. Khairi Mirza Samsudin from USM and Dr. Su Kahleng, also from USM. Before we start our session, I would like to remind all the presenters regarding the instruction for oral presentation. Number 1, please mute your microphone and turn off your camera. You can only switch it on during your Q&A session. The Number 2, the slides will be handled by person in charge. Number 3, once the slide video has ended, please turn on your microphone and camera for the Q&A session. Number 4, once your Q&A session has ended, please turn off your microphone and camera. I think that is crystal clear for the instruction. And without further ado, let us begin with our first presenter, which is M25 Munalizaini binti Mukhtar, with her presentation entitled Awareness and Incorporation of Dental Home Concept among the Ministry of Health Malaysia dental officers and dental therapists.
Assalamualaikum and greetings to the respected judges of International Postgraduate E-Symposium 2021. I am Munalizaini binti Mukhtar from School of Dental Science, University Science Malaysia, would like to share our findings on awareness and incorporation of dental home concept among Malaysian Ministry of Health dental officers and dental therapists. As introduction, dental caries of the deciduous teeth threatens more than 530 million children globally. In Malaysia, despite a declining pattern seen in a series of national oral health survey, the prevalence of tooth decay within 5-year-old preschool children remains alarmingly high. Concurrently, the caries severity has not shown significant reduction over the period of 20 years as shown in the table. The Oral Health Program of Ministry of Health MOH Malaysia developed the Early Childhood Oral Health Care Program in 2008, and also the Oral Health Program targeting pregnant mothers was established since early 1970s. However, low attendance to the dental clinic in both programs shows that some improvements in the provision of oral health services is indicated. An integration of these programs with new administration strategy to ensure provision of seamless care may help to prevent and control early childhood caries among children in Malaysia, and it would be the dental home. The American Academy of Pediatric Dentistry (AAPD) described a dental home as a continuing connection between both the patient and the dentist, encompassing all elements of oral health care administered in such thorough, always accessible, integrated and family-centered manner. To assist toddlers and their family in building a lifetime of excellent oral health, it must be developed before the age of 12 months. In Malaysia, the Oral Health Program of the MOH plays a tremendous role as the main provider of oral health care services at primary care. Therefore, the study aimed to assess the awareness and incorporation of the dental home concept among the MOH Malaysia dental officers and dental therapists. Specific objectives are to determine the awareness, factors associated with the awareness and the incorporation of the dental home concept into oral health care practice among Malaysian MOH dental officers and dental therapists. Method. This was a cross-sectional study involving the MOH dental officers and dental therapists in Malaysia serving at primary dental facilities, Malaysian MOH dental specialists serving at primary dental facilities, dental officers who are under attachment with dental specialist clinics or administrative dental office, and dental therapists who hold administrative position were excluded from the sampling frame of the study. Considering the available resources, a sample size of 360 dental officers and dental therapists were recruited. Mixed sampling method consisting of multi-stage sampling and non-proportionate stratified random sampling method were used to capture the sample size. A set of self-administered online questionnaire was used. The questionnaire has 3 parts as follows. Part A includes the socio-demographic background, Part B includes the incorporation of the dental home concept, and Part C includes the awareness of the dental home concept. The questionnaire was adapted from Hammersmith et al. 2013. The questionnaire had undergone the process of translation and adaptation as described by Beaton et al. 2000. The content validity and reliability of the questionnaire was established. Content validity of the Malay translated version was established by a panel of experts consisting of dental public health specialists, pediatric dentists, and MOH dental officer. The eligible respondents were contacted and invited individually via their official email. A brief overview of the study was given and the link to the Google form that includes the informed consent statement was provided. Informed consent were obtained from all participants. Data generated by the Google spreadsheet was transferred into the IBM Spss software version 24 for further data management and statistical analysis. Awareness and incorporation of dental home concept were analyzed using descriptive analysis. Chi-square test was used to determine the association of dental home concept awareness with years of service, location of facility, and job or post. Result. A total of 291 respondents participated in this study, giving a response rate of 80.3%. The socio-demographic background of respondents is presented in Table 1. Most of the dental officers were younger than the dental therapists, and majority of the respondents were females. The majority of the dental officers were recently graduated dentists. Majority of the dental officers serve less than 10 years, while most of the dental therapists serve more than 10 years. In terms of the percentage of treatment given to children aged 5 and below, the mean percentage was higher in the dental therapist group than the dental officers group. Table 2 shows the awareness of the dental home concept among the respondents. Most of the respondents have not heard of the dental home concept, suggesting that they were not aware of the concept. Only less than 30% of the respondents could correctly answer the dental home concept describe the ongoing relationship between a dentist and the patient. Additionally, only less than 40% of the respondents knew that the dental home concept should be established no later than 1 year of age. Table 3 shows the association between the awareness of the dental home concept with years of service, location of the facility, and respondents' job or post. None of the factors tested were found to be associated with the dental officers and dental therapists' awareness of the dental home concept. Table 4 shows the percentage of the respondents who incorporated the dental home concept into their oral healthcare practice. More than 80% of the respondents responded positively to all items measuring incorporation of accessible characteristics, family-centered characteristics, culturally effective, coordinated characteristics, and continuous characteristics of dental home concept into their oral healthcare practice. Additionally, more than 80% of the respondents responded positively to most items measuring incorporation of compassionate and comprehensive characteristics. Only one item in the compassionate characteristic, clinic will arrange payment plans, had less than 80% of the dental therapists responded positively. Another item with a low positive response was clinic provides special equipment and appliance therapy under the comprehensive characteristic. Discussion. All dental therapists are females because training for dental therapists for public services are only for females. Most dental officers are also females, reflecting the high number of female dental students in most dental institutions in Malaysia. Majority of the dental officers are in their late 20s and early 30s in accordance with the year of graduation. The percentage of treatment to 5-year-old was higher in the dental therapist group, reflecting the main job description of dental therapists, who are at the forefront of providing oral health care for children in Malaysia, complementing the role of dental officers in meeting the oral health needs of the young generation. Most of the respondents in this study had never heard of the term dental home concept. This present data is nearly consistent with Santos and Douglas in 2008 findings, where only 41% of dentists in the survey were aware of the AAPD dental home policy. However, the current study finding was higher than that obtained by Hammersmith et al. In 2013 that showed only 18% of Ohio general dental practitioners were aware of the dental home concept. While among the respondents who claimed that they have heard of the dental home concept, only 1/3 of the dental officers knew that the dental home concept should begin no later than the age of 1 year. This finding was lower than that by Sejasic et al. In 2008, who showed that more than half of Manitoba dental practitioners were aware of the AAPD recommendation that children should visit dentists by the age of 12 months. This current study findings was apparently better than studies shown by Hammersmith et al. In 2013, whereby only 7% of the practitioners could correctly identify that the dental home concept is a relationship between a dentist and a patient, and that it should begin no later than age 1 year. Findings of this study showed that the awareness of the dental home concept among dental officers and dental therapists was not associated with their years of service, facility location, or respondents' job or post. This result was in contrast with the findings by Hammersmith et al. In 2013, who discovered that dentists who recently graduated from dental school were more aware of the term. Findings of the study showed that the majority of the respondents incorporated the 7 characteristics of the dental home into their oral health care practice. The reason for favorable responses may be attributable to the professional commitment in addition to the standards of care and policies set by the MOH. Van Melson et al. In 2019 also demonstrated that professional duties influence dental practitioners' provision of infant-toddler dental homes in Alberta. This current result was consistent with the findings of Hammersmith et al. In 2013, who discovered that more than 90% of Ohio's general dental practitioners incorporated dental home characteristics into their practices. In this study, only less than half of dental officers responded positively to provide patients with specific equipment and appliance therapy. The most likely explanation is because in Malaysia, children who require specific appliance therapy and more complex treatment would be referred to and handled by pediatric dental specialists who are based at tertiary centers. This is one of the drawbacks of the current system that actually limit the accessibility of children to complex care, as the specialists are not available at the primary facilities that provide care for the majority of children in the community. Involvement of pediatric dental specialists in care of children at primary care settings perhaps can be introduced while maintaining their base at the tertiary care centers. In the same item, more than half of dental therapists gave positive response compared to the dental officers. It is likely because for the dental therapists, an unrestorable primary tooth is often used and considered as a space maintainer prior to the eruption of the permanent teeth. Hence, their idea of a space maintainer relates more to that practice than the use of properly fabricated space maintainers. In a conclusion, most MOH dental officers and dental therapists incorporated the dental home characteristics into their oral healthcare practice, although they were unaware of the concept. This study provides evidence that support the establishment of the dental home concept as an oral healthcare policy in Malaysia. These are my references. With that, I thank you for your kind attention.
Okay, thank you, M25 Monalizaini binti Mukhtar, for the presentation. Let us proceed with Q&A session of the judges. Judges, you can now proceed.
Dr. Su, should I start first?
Yeah, sure. Dr. Miza, you please start first.
Okay, all right. We maintain this consistency of the for the rest of the presentations.
Sure.
Okay, all right. Thank you very much for the presentation, Lizani. Just several questions. What is the feasibility of dental home concept in Malaysia? Because most of your studies refer to the other countries, but the feasibility of the dental home concept in Malaysia, is it within the dentist curriculum or something? Or is it in the Ministry of Health program itself?
Okay, first of all, thank you so much, Dr. Miza, for the question. Yes, for this research, actually, it's all from other countries, but not yet in Malaysia. But actually, most of it we already incorporated in our practice in Malaysia, but we don't have the dental home concept as a policy yet in our country, because this concept is considered quite new. For the AAPD also recommend this dental home concept and describe the definition of it since 2006, and this is quite new to our dental practitioners, especially in Malaysia.
Okay, thank you. How about the distribution of the questionnaire among states? Because you said that it's Ministry of Health dental officer or therapist in Malaysia. So are there any studies on the different locations within the states?
Thank you. Okay, thank you, Dr. Miza. So as you know that each states, we have the urban and also rural location. So we would like to know whether they incorporated this dental home concept in if there is any difference in the rural area and also urban facilities. So in this research, we divide equally to both urban and also rural facilities in Malaysia. We know that we have more rural facilities in Malaysia, which is 333 rural primary dental facilities and also 236 urban primary dental facilities. So each facilities are divided into 180 rural and also urban primary dental facilities for this research.
So that is part of your data, actually?
Yes.
Yes. Okay. All right. Thank you very much. To you, Dr. Su.
Hi, good morning.
Hi, good morning.
Yes. Okay. Is there any limitation in your study?
Yes, thank you, Dr. Su. So, of course, I have some limitation in this study. One of it is because the data was all self-reported by the dental officers and dental therapists. So it is possible that the actual treatment and also services delivered were not accurately reflected. And second is because this study was built using an online self-administered questionnaire. So the respondents with the intermittent internet connection will may be unable to participate, and that is explain why all the non-responders in this survey among the dental officers and dental therapists that are served in the rural areas. Thank you.
Okay, thank you. That's all for me.
Okay, thank you, judges. Okay, thank you, judges, for the Q&A session. Okay, next, let us proceed with our second presenter for today, which is M32, Aisyah binti Cik Rahimi, with presentation entitled Psychological Distress Among Malaysian University Students During COVID-19 Pandemic. Do religiosity and religious coping matter? Okay, I see technical.
Assalamualaikum and a very good day to all the honorable judges, guests, the committee members and participants of the International Postgraduate E-Symposium 2021. I am Dr. Aisyah Rahimi from the Department of Psychiatry, School of Medical Sciences, University of Science Malaysia, would like to present my research on psychological distress among Malaysian university students during COVID-19 pandemic. Do religiosity and religious coping matter? So the outbreak of COVID-19 in late 2019 had forced the government to enforce Movement Control Order, or MCO, to all citizens to prevent the spread of the virus. This had big implication on university students, as the term is most likely to be postponed and assignment and examination format may need to be revised. With closure of schools, colleges and universities in the middle of term, online classes were initiated. So based on previous studies, university students in Malaysia reported prevalence of psychological distress between 14.3% to 56% higher than of general population of 29% in 2015. So the impairment in psychological health of the students may lead to deterioration in academic achievements. This is especially of concern when it involves future healthcare providers like doctors, dentists, dietitians, and also our future leader. So religiosity as well as religious coping have been associated with mental health. However, the results were inconclusive. Some studies found them to be protective, while others found them to predict poorer mental health. So allow me to define religiosity and religious coping. Religiosity was defined as religious involvement in three major dimensions. Organizational religious activity, which is the involvement in public or organizational religious activities. Non-organizational religious activity, which involve religious activities done in private, and intrinsic religiosity, which are the degree of personal religious commitment and motivation. Religious coping is another construct or dimension of religion. It is defined as the efforts to understand and deal with life stressors in ways related to the sacred or divine powers. It can be divided into two sub-dimensions. Positive religious coping, PCOP, which is related to religious forgiveness, seeking spiritual support, collaborative religious coping, spiritual connection, religious purification, and benevolent religious reappraisal. And this coping side is actually associated with better psychological well-being. Negative religious coping and cope, which is spiritual discontent, punishing God reappraisals, interpersonal religious discontent, demonic reappraisal, and reappraisal of God's power is found to lead to negative impact on mental health. The objective of this study are to determine the psychological distress level in Malaysian university students during the COVID-19 pandemic. Second is to explore the association of psychological distress with religiosity and religious coping. And third, to determine other predictors contributing to psychological distress. So this study is a cross-sectional study taking place from March to June 2020 during the increment of COVID-19 cases in Malaysia. This study involved 450 undergraduate students from health courses of University Science Malaysia recruited through convenient sampling method. Questionnaires were distributed via students' email and social media groups, and minimal sample size required was 400 participants. So participants must be Malaysian, aged 18 and above. Any student who happened to be outside Malaysia was excluded. 4 instruments were used in this study. The socio-demographic questionnaires, Durell for religiosity or religious commitment, then brief RCOPE scale to measure religious coping, and general health questionnaire GHQ-12 for psychological distress. All questionnaires had good validity and had been validated in Malay language. For data analysis, Spss version 26 were used. Descriptive statistics were used for socio-demographic characteristic, level of religiosity, religious coping, and psychological distress level. To determine the predictors for psychological distress and the association with the level of religiosity and religious coping, multiple logistic regression was applied and the results were as follows. So for descriptive statistics of socio-demographic data of participants, majority of them were female, single, Malay and Muslims accounts for more than 73%. So based on the year of study, 52.4% were year 1 students, only 18% were in their final year, and for courses, 48% were in health sciences course, because the population of the students were more compared to dentistry and medical. As for funding, 82% of the participants received financial help, either loan or scholarship. Only 7.6% reported that they had medical disorder. 54.9% came from B40 groups. Nearly 80% of the students were locked down in the hostel during the study. 64.7% reported that they were in yellow or green zone, which had less than 20 active COVID-19 cases during the interview. A bit odd, as 80% were actually reported that they were at the hostel, so 80% should report the same zone. This can be explained as the situation of the pandemic was dynamic, and the students might answer the questionnaires at different time in which the status of local spread had changed. Now we look at the prevalence of psychological distress of the participants. With a cutoff score of 4 and above of GHQ-12, 36% of the participants actually experienced psychological distress at the time of study, which was higher than another study at the same setting during non-pandemic period. This finding was similar to the findings from the systemic review of psychological distress in general population around the globe during COVID-19 pandemic, which reported 34.4% to 38.8% of psychological distress. Next, we would like to look at the predictors of psychological distress. We include variables of the socio-demographic data, 3 dimensions of religiosity, and 2 dimensions of religious coping. So multiple logistic regression showed 5 variables had significant association with psychological distress, which are age, religion, zone, P-code, and also N-code, both dimension of religious coping. So younger age was found to be predictive for psychological distress because of adjustment to new environment and new life student. Muslim students experience more psychological distress than non-Muslims, owing for the religious practice were more disrupted than other religions due to the lockdown. Surprisingly, living in green or yellow zone, which had less active COVID-19 cases, is more distressing than living in red or yellow zone, contrary to the findings in other studies. It's possibly due to rural and suburban area, where the population were not as densely populated as the urban areas, hence less risk to contract COVID-19 infection. But in this area, there will be poor internet coverage. So this caused undue stress to the students as they depended so much on the internet for their online class. So this study actually strengthened the evidence that religious coping played a significant role in psychological well-being. High positive religious coping was found to be a protective factor by giving hope and optimism during this pandemic. Negative religious coping, on the other hand, focused on appraising COVID-19 pandemic as punishment from God, being left by God, believing that the outcome of the events as devil's act, and questioning one's relationship with the sacred. This can be highly distressing and associated with higher psychological distress. This study highlighted the mental health of healthcare students during COVID-19 pandemic and gave insight on the relationship of religion and mental health that was not explored much in our local setting. Limitation of this study was due to its cross-sectional nature, hence unable to establish causal relationship between religiosity and religious coping with psychological distress. We suggest to explore the students' concern in depth, especially on the academic-related events, which will give better enlightenment on how to tailor the educational system to suit the unmet needs of the student in the time of the pandemic. As a conclusion, level of psychological distress among university students during COVID-19 pandemic is high. Negative religious coping is predictive, whereas positive religious coping is protective of psychological distress. Hence, religious coping must be emphasized to boost mental health among students amid the pandemic. So these are my reference. With that, I thank you.
KPIC technical, can you pin me on the floor? Okay, thank you M32 Aisyah binti Cik Rahimi for the presentation, and let us proceed with Q&A session, and I will hand this session to the judges.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Isha. All right, thank you for the interesting presentations. So you did answer on the religiosity and the religious coping method. Just want to know, are there any differences between students staying at hostel versus students staying at home?
According to my research, there is no differences between both students who stay in the hostel and also stay at home. There's no significant difference.
So both shows the same psychological distress.
Yes.
Okay, all right. When we say about psychological distress, does it include depression, anxiety, or stress, or what does it mean actually?
Okay, psychological distress is actually any of the, we didn't specify any disorder, anxiety, or it's just a general general psychological well-being of the students at the time of the research. So GHQ-12 actually the questionnaire actually measure the distress level that if there's no intervention, will probably can lead to disorders such as depression or anxiety.
Also, we didn't, as your study didn't look at the severity of the psychological distress. Okay, thank you very much. Dr. Su, to you.
Hi, good morning, Aisha. Yeah, morning. Interesting study. Thank you very much for your presentation just now. So I just want to know, apart from religiosity, what are the other factors that may cope with the distress level, in your opinion?
There are a lot of, as we know, coping is actually when you respond to any stressor. So there are a lot of coping, and in this study, I was interested more on the how they cope in terms of religion. But there are a lot of other coping, and there's adaptive and also maladaptive. Basically, we have there are many types of coping. So I mean, getting support from family, friends may also be type that coping. Exercise is one of the coping skills. So there are a lot, but it will depend on you which one can help you in terms of stress.
Yes, exactly, Aisha. That's why I just wonder, you not investigate other coping method, right? So perhaps there are other underlying factors that control the stress, and not because of the religious itself, but because you not investigate. So you should discuss this. Because you not investigate the confounder, the underlying factors, so you only focus on the religious. So the result might not
portray the scenario of the student.
Yeah, because there are other factors as well, which is not controlled in your study. Okay, that's all.
Thank you very much.
Thank
you very much, Dr. Su, for the input.
Okay, thank you all the judges for the Q&A session. Okay, we shall proceed with our third presenter, which is M33, Roslina binti Muhammad Fazilahmah, to present with presentation entitled Assessment of Oral Health Knowledge, Attitude and Practice of Caregivers of Children with Autism Spectrum Disorder.
Ladies and gentlemen, Assalamualaikum and hello. My name is Roslina. Do you know that children with autism spectrum disorder need constant oral health care from their caregivers? Therefore, in this presentation, I'm going to share with you the findings of the caregivers' knowledge, attitude and practice in their children's oral health care. Autism spectrum disorder, or acronym known as ASD, is a behavioral syndrome affecting the social communication, showing repetitive behaviors and restricted interests. It can be detected as early as 3 years old and affecting more males than females. The characteristics of ASD can affect their oral health status. To the best of our knowledge, there is insufficient local study on the assessment of the caregiver's oral health KAP. Adequate oral health KAP is crucial, and the findings from this study would be a basis to plan a more comprehensive education program for the children. Generally, we would like to assess the oral health KAP of caregivers of children with ASD, and specifically, we would like to determine the knowledge, attitude, and practice. This is the research question and research hypothesis. Our study is a cross-sectional study and was conducted at the Oral Health Specialist Clinic Hospital USM. Our source population included all caregivers of children with ASD aged 7 to 12 years who registered at the Psychiatry Clinic Hospital USM. We included caregivers aged 18 years and above and excluded those with mental disability and hearing impairment. For the sample size calculation for objective 1, 2, and 3, we used the single proportion formula. This is our sample size calculation. In summary, the highest sample size was 72 subjects. However, there was a total of 68 ASD patients in the Psychiatry Clinic Hospital USM. Therefore, all 68 caregivers were included in our study. We included the proforma, which consists of the caregivers' profiles and questionnaire regarding oral health knowledge, attitude, and practice, adapted from Ngah et al. The questionnaire has 3 domains and 22 items. These are the items for the knowledge, attitude, and practice. This is the data collection procedure. Data entry and analysis was done using the Spss IBM version 26.0 and descriptive analysis was done. This is the ethical approval. Most of the respondents were mothers. Mean age of all respondents was 39 years old and all were Malays. 34.4% of the caregivers received STPM education level. 37.5% work in the government sector. 46.9% were categorized as low income. 59.4% of the caregivers came from Kota Baru. 65.6% answered that sugary foods or drinks are best limited to meal times, and 84.4% answered that it is preferably for a child to eat a bag of sweets gradually consistently. 75% answered fruit-flavored drinks are safe for children's teeth, and 59.4% answered most syrup medicines contain sugar. 53.1% thought that the child needs to start oral hygiene care when first tooth come through. 93.8% knew that brushing teeth or gargle after meals can prevent caries. 59.4% knew that children need to brush twice daily, and 68.8% knew about pea-sized toothpaste for children. 87.5% knew that fluoride strengthens enamel. 34.4% thought that the child's age to start visit dentist is 13 to 24 months. And 87.5% knew that dental visit is for checkup. For oral health attitude, 43.8% strongly agreed that there is a need to concern about baby teeth, and only 18.8% who strongly agreed that it is worthwhile to fill a cavitated baby tooth, although it will be replaced by a permanent tooth. 75% strongly agreed that regular dental visits are very important. 71.9% felt that dental filling is required if a child has a cavity in a permanent back tooth. 62.5% felt that dental filling is required for a cavitated permanent front tooth. 68.8% strongly agreed that brushing twice daily for 2 to 3 minutes maintains a good oral health. 65.6% of the caregivers felt that the child needs to be assisted by an adult when brushing. For oral health practice, 37.5% claimed that the child brushed twice daily. 87.5% used toothpaste when brushing. 62.5% used toothpaste with fluoride. And 46.9% used pea-sized amount of toothpaste. Most of the caregivers were mothers and all respondents aged between 31 to 47 years. These caregivers' children aged 7 to 12 years mostly attended government primary schools, received dental treatment from the Ministry of Health or other resources, and attended the occupational therapy in Hospital USM. The majority of caregivers had secondary education and were employed. Consistent with the survey by the Department of Statistics Malaysia, the caregivers had low income and earned below 4,000 ringgit Malaysia. We managed to obtain 100% response rate from the 32 respondents. 65.6% answered sugary foods or drinks are best limited to meal times. Children with ASD prefer snacking between meals. Their frequent sugar exposures can lead to dental caries. 53.1% answered child's age to start oral hygiene care when first tooth come through, which was incorrect. The correct answer is at birth. It was found that 5% children had delayed eruption or missing teeth. Therefore, dental checkup is recommended for infants and young children. 43.8% were strongly agreed that there is a need to concern about baby teeth. According to Al-Humaid et al., caregivers performed oral health care for their children only when oral health problems occur. 65.6% answered that their children were assisted by an adult if they insist on brushing on their own at a very young age. Children who are brushed by the caregivers have a better dental health and lower caries prevalence. 62.5% used fluoridated toothpaste for child. Some caregivers refused fluoride, and these are the caregivers who refused vaccination as well. 46.9% used pea-sized amount of toothpaste, which provide protection against dental caries. It was reported that most of caregivers dispensed oversized toothpaste for their children. Limited sample size obtained due to less children with ASD aged 7 to 12 years available in psychiatric clinic and declination of invitation by the caregivers. Data collection took longer time than expected because appointments were mostly on the caregivers' availability as they need to manage their children at home, and many requested to be on the same day as the occupational therapy in USM hospital. We recommended that awareness programs should be developed for caregivers to encourage them to seek preventive oral health care. Caregivers should be encouraged to seek professional oral health counseling as soon as possible. Future studies need to be conducted with bigger sample size and include severity of ASD and difficulties faced by the caregivers during their children's toothbrushing routine. To conclude, caregivers of children with ASD displayed a basic understanding and attitude on oral health. However, the practice towards oral health care was unsatisfactory. Oral health intervention for caregivers is crucial as they play a major role in caring their children. I would like to thank Prof. Dr. Mastura, Dr. Munira, and Dr. Nozila for their guidance and advice, as well as the participants in the research, my husband, family, and friends. These are the references. Thank you.
Okay, thank you, M33 Roslina binti Muhammad Fazilama, for the presentation. Let us proceed with our Q&A session. So I handle the session to the judges.
Thank you very much. Assalamualaikum warahmatullahi wabarakatuh, Dr. Sina. All right. You did mention on the limitation or in terms of your respondent, right? So why did you concentrate only respondent from USM hospital comparing to other respondent in Kelantan or respondent in other states itself?
Okay, good morning, judges. Good morning, Dr. Miza. So, thank you for the question. Actually, this was the initial plan where before the COVID-19 pandemic, we were supposed to compare this group of children with other children with ASD in other states. So, due to the pandemic, we cannot visit the ones in other state, and we just need to do the research onto these children.
So does this mean that this is done face to face rather than through online questionnaire or anything?
Yes, this was done face to face, and actually this is only part of our study, and we also did post intervention where we did the second part of the KAP through phone calls as well.
All right. My concern is because your title did just say about children with autism spectrum disorder, but didn't state the specific, because there I'm not sure. There might be a bias comparing to children who go to USM hospital and children who just go to a normal. Because yesterday there's a presentation on autism as well. They have one NGO, they collect data from the NGO. So there might be a different knowledge given by the organizations comparing to what's being given in the SM. So that's my concern in this in your topic itself. Maybe just change the title of the topic might help you to get a better understanding.
Okay, thank you, Doctor.
All right, you're welcome. Dr. Su, to you.
Hi, thank you, Dr. Mizal. Good morning.
Good morning, Dr. Su.
Yeah, good morning. Do you have data on the prevalence of these autism children in Kelantan?
In Kelantan, we do not have the prevalence, but we have the one that produced by the Ministry of Health for the whole Malaysia.
Okay, what is the prevalence? The current prevalence?
The current prevalence, it was in a few years ago, it's about 16 over 10,000.
16, 16.
16, yes.
Per 10,000.
10,000, yes.
This is the autism children?
Autism children, yes.
Okay. I only have one question.
Okay.
What would you expect? Okay, would you expect a different finding if this study is carried out among a normal children's caregiver?
Okay. For the oral knowledge, researchers in other countries shows that the knowledge of the caregivers of children with ASD was higher compared to those non-ASD.
Oh, I see.
Yes.
So that means normal children's caregiver, they have a lower level of KP.
Yes, KP.
Oh, interesting. Why like that?
Because if according to the researchers, This particular parents, they have training and they have a lot of readings, and also they are very they're very well into their children's health, not only oral health but also general health.
So they are more concerned about their children.
Yes. And then they look for more information compared to those parents without autism.
Okay, thank you. That's all from me. Thank you.
Okay, thank you, Dr. Sue. Thank you.
Okay, thank you, judges, for the Q&A session. We shall proceed with our next presenter, which is M36, Suhaila binti Mat Said, with presentation entitled Perception of Risk Getting Infected COVID-19 and Associated Factors Among Oral Healthcare Workers in Attending Patients During COVID-19 Pandemic in Malaysia.
Assalamualaikum. Hi to everyone. I'm Suhaila binti Mat Said. My supervisor is Dr. Muhammad Zulkarnain bin Sino and my co-supervisor Dr. Basaruddin Ahmad and Dr. Sarliza Yasmin Sanusi. This presentation titled Perception of Risk Getting Infected COVID-19 and Associated Factor Among Oral Healthcare Workers in Attending Patients During COVID-19 Pandemic in Malaysia. There is my outline of my presentation. The novel severe acute respiratory syndrome coronavirus, namely COVID-19, emerged in December 2019 from Wuhan, China, fast spreading globally and has been declared as pandemic by World Health Organization on 11 March 2020, become a major occupational challenger for healthcare workers in year 2020 as they show a high tendency of contracting COVID-19 due to the close contact of patients affected by this virus. Oral healthcare workers who deliver care and services to protect and improve the health of their communities. Dentistry is considered as one of the most high-risk territory of spreading disease. According to WHO, 1/10 healthcare workers are infected with coronavirus in some countries. On 10 October 2020, 579 of healthcare workers have been infected by COVID-19 since the pandemic began in Malaysia. In the process of preventing and controlling the disease, oral healthcare workers also face higher risk of disease transmission due to the dental treatment operation involving uses of various instruments. The aim of the study to assess perception of risk getting infected COVID-19 among oral healthcare workers in attending patients during COVID-19 pandemic in Malaysia. The specific objectives are: Objective 1, to assess mean score of perception of risk getting infected COVID-19 among oral healthcare workers in attending patients during COVID-19 pandemic in Malaysia. Objective 2, to determine factors associated with the perception towards of getting infected COVID-19 among oral healthcare workers in attending patients during COVID-19 pandemic. This is a cross-sectional study that used a self-administered questionnaire on 199 oral healthcare workers conducted from February until early June 2021. This study involved 5 states in Malaysia, namely Perlis, Selangor, Negeri Sembilan, Kelantan, and Labuan. Multi-state sampling technique was applied to determine the location of the study. Inclusion criteria: oral healthcare workers who are involved in clinical tasks during COVID-19 pandemic and able to access Google Form. Exclusion criteria: oral healthcare workers who work at the hospital base and oral healthcare workers who had already contracted COVID-19. 204 oral healthcare workers were needed in this study. The study design: selection of sampling frame using convenient sampling for oral healthcare workers. A structured self-administered questionnaire used in this study was adapted from a study of SAR risk perception. We also modified the questionnaire originally developed from SAR risk perception and included several features specific to COVID-19. Therefore, the questionnaire consisted of 3 sections with 24 items. This questionnaire has gone through content and face validation by 6 experts in their field. Pre-test was done to 10 oral healthcare workers at Klinik Pergigian Bandar Botani, Klang Selangor. An online survey was conducted in May 2021, and the pre-validated questionnaire via Google Form was sent to the target sample to collect the data. The validated questionnaire in the Malay language was disseminated among oral healthcare workers. The data for oral healthcare workers were obtained from the Deputy State Health Director of Oral Health Division after getting the permission from the Ministry of Health Malaysia. The data were entered and analyzed using statistic package of social science statistic version 26 software. There is a result. The data respondent social demographic are shown in table 1. A total of 199 oral health workers were involved of this study. Table 2 shows the mean score on the knowledge of preventive measure and the perception of risk among oral healthcare workers in attending patients during the COVID-19 pandemic. It showed the mean score of present study. The risk of getting infected of COVID-19 was high among oral healthcare workers. Table 3 shows the risk perception score and the result of multivariable analysis among oral healthcare workers in Malaysia. Job category and highest education level were influencing factor risk perception. Dental officer had a higher level of risk perception than the other job category. This risk perception of an oral healthcare worker was headmaster or doctorate had a highest level of the risk perception with 3.01. Table 4 showed that there was a very weak relationship between the variable. The value of the goodness of fit model is shown in table 5. There is 1.76. Therefore, there were no significant association between demographic factor and knowledge with the perception of getting infected by COVID-19 among oral healthcare workers. Dental clinic is a workplace for oral healthcare workers to do their roles and responsibilities. They spend most of their time at the workplace. Currently, due to the COVID-19 outbreak, the transmission of COVID-19 can occur at the dental clinic. A total of 199 oral healthcare workers were involved in this study, which show more female compared to male. There were more female because oral dental therapists in Malaysia are pioneered by female. The findings show that the mean score on the knowledge of preventive measure was high, in which oral healthcare workers relatively believe that the uses of personal protective equipment and following the guideline can prevent them from contracting COVID-19 virus. The finding constructed on the study of healthcare workers which show a relatively low importance of personal protective equipment, whereas the World Health Organization guideline consider the importance of using of personal protective equipment in preventing healthcare workers from influenza virus. Therefore, universal protocol or guidelines are crucial in order to maintain the best practices and recommendation when delivering oral health services during the COVID-19 pandemic. The mean score on the perception on risk getting infected by COVID-19 among oral healthcare workers when attending patients during a pandemic was high. It showed that oral healthcare workers left concerned about their risk exposed to COVID-19 infection when attending patients. The finding was similar to other studies of oral healthcare workers in which the oral healthcare worker and the family were concerned about the potential of contracting COVID-19 while doing the job. This concern may have an effect on the level of commitment of oral healthcare workers during a pandemic and should be addressed in any dental facility preparation plan. There was no significant association between demographic factor and knowledge with a perception toward risk of getting infected by COVID-19 among oral healthcare in attending patients at dental setting in this study area. The finding of this study contrasts with those of previous study among college students in China. We found that demographic factor and knowledge preventive measures were correlated with risk perception of COVID-19 among them. There was some study limitation being remarked. This study took place in 5 different states. However, due to technical problems regarding permission letter for authorities, only 3 states were responded. It is possible that this will limit the generalizability of the data and the finding. Conclusion. It was concluded to present study the risk of getting infected of COVID-19 was high with no factor are associated with the risk. That's all from me. These are references. Thank you.
Thank you, M36 Suhaila binti Mat Said for the presentation. We shall proceed with our Q&A session with the judges. Judges, you may now proceed.
Okay, all right. Cik Suhaila Mat Said. All right, thank you very much for your presentation. I just need to confirm several things that you mentioned just now. So, you did mention oral healthcare worker working at hospital are excluded. Can you elaborate on that? Why they are excluded?
Thank you for your question, Doctor. Because mainly more oral healthcare worker are working at the dental clinic. And then because of I consider the resources and the limited of time, so that's why I focus on at the dental clinic. And then dental clinic is a first place that the patient come to get the treatment, to the dental treatment. If any further treatment, they will refer to the hospital. That's why I did only to the dental clinic. In the dental.
So you mentioned just now, thank you for the answer. You mentioned just now, I think it's around 199 respondents. So I believe the number of dental healthcare worker should be higher than that. So how do you know that you have enough data if you only collected from 199 respondents?
Actually, from the estimate, my sample size only required 204 for oral healthcare worker. But I only get the response from the oral healthcare worker only 199.
Okay, all right. So maybe you should put this in the limitations, or I think it's just another 5. You can force, not saying force, you can ask some assistant to complete your data at the end of the day. All right, thank you very much, Dr. Su. To you.
Hi, thank you, Dr. Mizal. Good morning. Suhaila, how are you today?
Good morning, Doctor. I'm fine.
Your title is about perception of race getting infected COVID-19. And then in your result, you have some results on the knowledge and also perception, right? Okay. So your title is about perception. May I know can you give one example of your question item that asks about perception, and then one item that asks about knowledge?
Okay. Thank you, Doctor. For example, in the perception, I asked about their fear, or not get their fear, and about their fear. Sorry. about their fear to get the infection while treating treating patient.
Yes.
And then regarding the knowledge, I asked perception. I asked about the uses of the PPE. For example, is it wearing a mask? And then prominent notice in the clinic, is it there? The physical distancing, and then regarding the more regarding the PPE.
Okay. So since you have quite your result, there are a lot on the knowledge, right? Why your title not include knowledge? Only perception. Yeah. And then and okay, it's fine. And then your conclusion, you mentioned about the risk was high. Right? There's one statement. Your conclusion is that the risk of what? Again, the risk of getting infected COVID-19 is high. Am I right? So
Yeah.
I can't see the conclusion. I can't relate your conclusion with your finding because your finding is about the perception, the knowledge, but you not assess the risk. When we say the risk is high, it refers to what? You need to measure the cases, right? The incidents. Yeah, we need to infer, relate incidents. Generally, we can conclude about the risk is high or not. But in your case, it's only the perception, the knowledge. So that's why I think your conclusion is not related to your finding. Okay, that's all. Thank you.
Okay, thank you, Doctor.
Okay, thank you, judges, for the Q&A session. Let us proceed with our next presenter, which is M38, Ruzawani binti Ruslan, with presentation entitled Age and Factors of Smoking Initiation Among Military Community in Kelantan.
Assalamualaikum and salam sejahtera to all. I am Major Dr. Ruzawani binti Ruslan, postgraduate student of Doctorate in Dental Public Health, will be presenting an oral presentation entitled Age and Factors of Smoking Initiation Among Military Community in Kelantan. These are my outlines of the presentation. As for introduction, cigarette smoking is one of the risk factors for chronic diseases which may affect the health readiness of army personnel. Knowing the age and factors to initiate smoking among military population allows appropriate intervention for smoking cessation. Thus, objective of this study is to determine age and factors of smoking initiation among army personnel in Kelantan. For the methodology, a cross-sectional study was carried out on December 2020 among 134 voluntarily involved infantry army personnel who smoke in Kelantan. Based on study by Lim et al. 2020 on prevalence of smoking and its associated factors among secondary school students in Kelantan, Malaysia, the study sample required was 1,500 subjects. Due to the limitation of study period and pandemic condition, we only got this amount of respondents who volunteered to involve in this study. The inclusion criteria for sampling framework, the respondent should be a regular or occasional smoker and using smartphone with access to the internet, while respondents who were computer illiterate were excluded from the study sample. There were two research tools being used in the study, including first, an invitation poster for respondent recruitment spread through WhatsApp application. Interested respondent contacted researcher for registration and consent. Second, Google Forms were being used to elaborate on research procedures, written consent, as well as to deliver a self-administered validated personalization questionnaire to assess army personnel's history of smoking use. Ethical approval had been obtained for this study from Jawatankuasa Etika Penyelidikan Manusia USM as a study being delivered through online medium due to pandemic condition. For the statistical analysis, descriptive statistics were calculated using SPSS version 26. The results of this study were as follows. Figure 1 shows socio-demographic profiles of respondents. There were 134 respondents for the study. All respondents were male, majority of them were Malays. Other ethnic involved in the study includes Iban, Bidayu, Bugis, Bajau, Murut, Kadazan, Bisaya, and Rungus. Continuous data shows not normally distributed data. The median age of respondents was 25 with interquartile range of 11 years. The median income was 1,700 ringgit with the interquartile range was 565 ringgit. Most of them received the highest level of education at secondary school, while others went to higher institutions. Most of them were having marital status of single and live in the camp. There were 2 camps involved in this study from simple random sample of camps in Kelantan, which were Camp Pekalan Cepa and Camp Batu Sebelas Tanah Merah, Kelantan. Figure 3 shows a skewed distribution on histogram of age started smoking. Thus, the median age for started smoking was 15 years with the interquartile range of 4 years, which was acknowledged as adolescent years according to World Health Organization. Table 4.1 shows factors associated with the initiation of smoking. There are 4 factors being accepted from this open-ended question item, which most common factors was curiosity with 59.2%, followed by influence by friends 53.8%, stress 17.7%, and last but not least, influence by family members 3.1%. Table 4.2 shows the percentage of respondents having history of using drugs and history of addiction. There were 12 respondents had a history of using drugs, with the most of them did not reveal the substance. 2 of them used sniffing substance in the past and 1 used methamphetamine. Only 4 respondents revealed history of addiction to alcohol. As for the discussion, age started smoking in this study was during adolescent years, with median age of 15 and interquartile range of 4 years. It is consistent with a study among 1,700 secondary school students in Kelantan, where almost 2/3 of them started smoking before the age of 14 years old. The findings also consistent with a study by Abdul Razak et al. 2021 on abuse of substance in Malaysia, with common practice of smoking, methamphetamine use, and glue sniffing often starts during adolescence. Factors that initiate them to smoke also consistent with other study among adolescents at national and state of Kelantan level, including having pills for smoking, having family members who smoke, positive attitude towards smoking practice, and poor academic achievement. These phenomena pose a threat and require public health intervention, including enhanced health promotion, revision of existing anti-smoking measures, enforcement of stricter policy and regulation, as well as increased availability of healthcare services offering help. The uniqueness of military culture allows for innovative means of tobacco regulation and prevention, including regimental and medical rehabilitation. This includes strict policy on smoking availability at training center, smoking-free camp, promoting healthy lifestyle, and proper smoking cessation help center. As for the conclusions from this study, it was concluded that Army personnel initiated smoking before enlisted in the force. curious about smoking, feel influenced by friends and family members, as well as stress were found to be the factors of smoking initiation among army personnel in Kelantan. This is my acknowledgement and references. With that, I thank you.
Thank you, M38 Rozawani binti Ruslan for the presentation. We shall proceed with Q&A session with the judges. Judges, you may now proceed.
Okay, thank you very much, Major Dr. Ruzawani. Ruslan. Okay, interesting studies. I just want to confirm only one thing. You did mention that you exclude computer illiterate personnel. So, in your opinion, what will that impact on your study itself?
Thank you, Doctor, for the question. Actually, for the research tools, we are using an online medium, which is the Google Form. So, among military personnel, if they cannot operate with the computer, we might afraid that the answer might be wrong due to the administrative factors.
Are the numbers high, or do you have the numbers in place, or is just an assumption that some of them might be computer illiterate? Because it's in a way most people have a smartphone nowadays. I'm not sure people who do have smartphones. Maybe you have this data with you or something.
I didn't have the data, but I actually did a pilot study to distribute the Google form. And one of the problem is that they cannot fill the form. Few of them. So we need to include the exclusion criteria for that.
Okay, all right. Thank you very much, Dr. Sue. To you.
Thank you. Yes, good morning, Rosawati. Thank you, Dr. Mizal.
Good morning, Doctor.
Yes, yeah, good morning. Very surprising. Your result finding shows that the smoking initiation is at around 15 years old, right? So based on these findings, what would be your suggestion, okay, to Malaysian government, perhaps? Thank you.
Okay, for participants' attention, actually, regarding the initiation age for smoking during adolescence, actually we in Malaysia have a very comprehensive program in the schools, actually, involving also the dental health personnel. We have a program under Ministry of Health known as KOTA, Kesihatan Oral Tanpa Asap Rokok. So they targeted all the school children since the primary school to the secondary school through annually dental checkup to find if any localized condition that present in the mouth, so that we can counter if they practicing smoking among these school children. And then in the program, the school children being tackled and intervened through behavior program in the primary healthcare facilities.
But in your opinion, why the prevalence of smoking still very high among adolescents? Although we have such good program in the school, what's the main problem, do you think?
This study involved previous data, which is now the respondent is in adulthood. So we want to know their history of smoking, when they start to initiate smoking. So I believe now the prevalence is improving. However, we still need to continue with a rigorous program to counter this smoking problem within Malaysia.
Okay, thank you, Ruzawati. Thanks a lot. Bye.
Thank you, Dr. Su.
Okay, thank you, judges, for the Q&A session. Let us proceed with our next presenter, which is M35, Vinovan Kuna Anak Lelaki Kuna Sagaran, with presentation entitled Oral Health Knowledge, Attitude and Practice Among Primary Caregivers of Virtually Impaired Children at Hospital University Science Malaysia, a preliminary study.
Greetings and a very good day to our honorable judges, moderator, and fellow participants. I am Vinovan Kuna, would like to share my study findings on the oral health knowledge, attitude, and practice among primary caregiver of visually impaired children at Hospital University Science Malaysia. These are the content of my presentation. First and foremost, visual impairment or visual loss can be defined as the decrease in the ability to see to an extent that it might cause a problem that is not treatable by usual means, such as glasses, and blindness is the complete or nearly complete vision loss. It can be classified based on the visual acuity level as shown in the table. The oral health status of the visually impaired children are relatively poorer when compared to their normal peers, and this can be due to various reasons such as difficulty in learning motor skills, hand and eye coordination, inadequate supervision by their caregivers, and severity of their acuity level. Caregivers have shown to have a significant role in their children's oral health care, and even more so among disabled children. Studies have shown that visually impaired children are heavily dependent on their caregiver to help and assist them in their daily activity. Besides that, the good oral health status among children have shown to have been related to their caregivers' dental awareness and oral health knowledge, attitude, and practice. From these slides, studies have shown that poor oral health knowledge, attitude, and practice were noted among caregivers in various regions. Therefore, the main objective of these studies is to determine the oral health knowledge, attitude, and practice among caregivers of visually impaired children in our local setting. And this is the conceptual framework for this study. Materials and methods. This study was a cross-sectional study design and took place at the Pediatric Ophthalmology Clinic and Specialist Dental Clinic at Hospital University Science Malaysia. The source of population is primarily Malaysian primary caregiver of their visually impaired children who receive treatment at the Pediatric Ophthalmology Clinic, Hospital University Science Malaysia. And the inclusion and exclusion criteria are as mentioned. This shows how the sample size of the study was derived. Convenient sampling method was used for the study and the ethical approval was obtained. The research tool for this study is a validated self-administrated questionnaire which was adapted from Ngah et al. Part 1 of the questionnaire is on the socio-demographic profile which consists of 6 items. The second part of the questionnaire is on the knowledge towards children's oral health and consists of 11 items. The scoring is based on the correct and wrong answer given by the participants. The third part of the questionnaire is on the attitude towards children's oral health and consists of 7 items, and the scoring for this part is based on the Likert scale. The final part of the questionnaire is on the practice towards children's oral health and consists of 7 items, and the scoring is also based on the Likert scale format. And this is the summary of the scoring system. And this is the overall flow of the data collection procedure. This slide shows the summary of the statistical analysis, study results. Based on the socio-demographic profile, majority of the participants are mothers and are of Malay race. About 48.1% of the participants are having secondary school education level. Besides that, 70.4% of the participants are of low income category, and the main source of oral health education among the participants are from doctors, nurses, and healthcare providers. In relation to the oral health knowledge, A key point to be highlighted is that most of caregivers do not understand the relationship between frequency of exposure time towards sugary food and dental caries, as been highlighted in question 2. Besides that, majority of the caregiver presume that most medication are sugar-free. Moving on, only about 18.5% of the caregivers actually noted using pea-sized amount of toothpaste for their children daily toothbrushing. Majority of the caregivers understands that fluoride strengthens the tooth enamel. Besides that, most of them reported that they take their child to the dentist for dental checkup. However, when it comes to which is the right age to take their child to the dentist, most of them only respond that they only take their child during school level. When it comes to the oral health attitude, most caregivers agree that great importance should be in place towards deciduous tooth. Besides that, caregivers in these studies have shown positive attitudes towards regular dental visits, frequency of toothbrushing, as well as restoration of tooth. However, as we can see from this slide, only 44.4% of the caregivers actually assist their children toothbrushing during their early stage of their life. From this slide, most of the caregivers noted that their children have started practicing brushing twice in a day. However, it's quite concerning to know that there are some participants who actually noted that their children only brushes once in a week. In terms of toothpaste usage, all of the participants have noted that their children have started using toothpaste. From these findings, we can actually see that most of the caregivers practicing half of the toothbrush head in terms of the amount of toothpaste used. Besides that, in terms of sugary food exposure between meals, most of the caregivers noted that they rarely expose their children to it. Similar response were also noted in terms of sugary food consumption during the weekend, which are rarely. Next, we move on to discussion. The study findings on socio-demographic profiles were comparable to the data at the Department of Statistics Malaysia 2019, whereby most of the population in Kelantan are from the B40 category. The study also noted that the main source of oral health information is from the doctor and oral health care providers. This is very positive as study done by Taniguchi in Japan in 2017 showed that oral health information obtained from the dentist showed better positive result on oral health behavior. Moving to the oral health knowledge aspect, about 55.6% of the caregivers mentioned that sugary food and drink should be limited to main meal times. These results are somewhat satisfactory. However, there are a great majority of the caregivers still do not understand the importance of limiting the number of sugary food and drinks exposure based on the question 2 of the knowledge item that has been previously discussed. Besides that, only 14.8% of the caregivers knew that child's oral health care starts even before the teeth erupt. These findings were much lower than the result in a study done by Ratmawati in 2017. Studies have shown that children who started toothbrushing earlier have less caries. In terms of oral health attitude, majority of the caregivers knew the importance of taking care of their children's disease state. This is being supported by a study done by Lopez Gomez in 2016, whereby deciduous dentition plays an important role in mastication, phonetic, and development of jaw and muscle. However, our current study findings noted that only 44% of the caregivers assist their children in toothbrushing during their early years. Based on the American Academy of Pediatrics, toothbrushing should be performed for children by parents till the age of 6 years old and thereafter been assisted by. VI children may require longer assistance. In relation to the caregivers' practice on children's oral health, majority of the caregivers mentioned that the amount of toothpaste used by their children covered half or full head of the toothbrush. Besides the beneficial factor of fluoridated toothpaste, caregivers should be more aware of the toothpaste use and the amount used by their children to avoid harmful effects towards their child's health. In the present studies, 37% of the caregivers noted that their children did have sugary food between meals at least several times in a day or during the weekends. Study done by Mayer and Annex in 2018 have noted that frequent exposure of sugary food has shown to have carcinogenic effect towards tooth surface. In conclusion, despite having a high mean SD of oral health attitude and practice score at 23.2 out of 28 and 12.8 out of 19 respectively, however, less than half of the primary caregiver actually assisted their children in brushing their teeth in their early age, and the caregiver oral health knowledge was relatively low at the mean SD of 5.5 out of 11. And these are several recommendations for future studies. Number 1, to include a larger number of sample size. Number 2, development of customized education material. Number 3, multi-sectorial approach. And number 4, emphasize on the role of parents. And these are my references. We would like to acknowledge and thank all primary caregivers of the visually impaired children who have voluntarily participated in this study.
Okay, thank you. M35 Vinovan Kuna, anak lelaki Kuna Sagaran for the presentation. We shall proceed with our Q&A session. I would like to invite judges to proceed.
All right. Good morning, Mr. Vinovan. Hope you are doing well.
Very good morning, Doctor.
Okay, just one question. It's an interesting study, and I do realize that it's still as a preliminary studies. When do you make preliminary studies? Do you have the possibility that you will expand this to throughout Malaysia or throughout Asia or something?
Yeah, thank you so much for the question, Doctor. Very good morning. Yeah, the initial idea was actually to look at the caregivers' oral health knowledge in the Kelantan population itself, first of all, and furthermore, in the later part, we would like to extend involving throughout Malaysia, because as we know, the determinants of the oral health knowledge can be due to various factors. However, because the study has been progressing towards the start of the pandemic during that time, so unfortunately the study has to be abandoned halfway through the data collection procedure method. However, the good thing is that we managed to get a good number of sample size as well. However, that is why during the recommendation part, we do suggest that maybe the study should include a more expanded in terms of sample size, as well as more exposure in terms of where the determinants, or maybe in terms of urban and urbanized areas, and in terms of the social demographic profile of the participants itself. Yes.
All right, thank you very much. And you mentioned just now towards the pediatric, your population, with pediatric caregivers, right?
Yes. For currently, we are only targeting the caregivers who are having visually impaired children only, not involving adult visually impaired.
How do you confirm the data given by the caregivers itself? So are there possibilities that the caregivers didn't fully know what their kids maybe brush their teeth more than twice a day, for example? So how do you confirm this?
Okay, that's an interesting question. Thank you for answering that. So, okay, we do take that in mind in terms of what is the possibility of how their diet patterns, and in terms of their brushing skills and everything. So that is why we suggest the caregivers in terms of answering this question. We do not want them to bring back the questionnaire. We do actually ask them to give them a period of time during that particular session itself when we interview them. So they will answer it on the spot. So if they relatively are not sure about a particular answer and everything, so they will usually, because we are conducting it one-to-one, so we are able to assist them in terms of anything. So in terms of any doubt, they will question us. So in terms of they are not too sure, we will ask them to mark what do they feel in terms of relatively but we'll put there some extra. Why do this data is important is that shows how attentive of their parents towards their oral health care needs. So that is what we want to know also, in terms of, because the idea is to involve parents as a role model towards their children in terms of identifying, do they actually actively play the role in terms of guiding their children? Because as we know, habits and behavior needs to develop over a period of time. It doesn't come in the first time as you teach your children. It doesn't automatically generate themselves. So those are the things that we are looking for. So we do put an extra mark in our questionnaire that we answered and everything for the parents who are not sure about the particular question.
Excellent. Thank you very much, Dr. Sue. To you.
Yes, good morning, Mr.
Good morning, Doctor.
Yeah, good morning. Very interesting study. However, I noticed that the sample size is 27, right, in this study?
Yes.
What is your actual minimal calculated sample size?
Okay, the minimum calculated sample size is supposed to be 82. Okay,
82.
That's 82, which is the supposed target one. That's what we targeted and everything. So the during the sample size collection, it started somewhere around February to onwards, February onwards in 2000 last year, actually 2020. So, however, the university has released a circular saying that no data collection and clinical research should not be taken place from the 18th of March onward. That is during our first MCO.
Yes.
So that is where all the data collection have to put on hold. However, because we do have the 27 participants that are already collected, so that is where we started to think, okay, why not we convert it into a preliminary study first? So we do not consider it as a main study first. We consider it as a preliminary study. So once we get the proper amounts, probably include a larger sample size. If you want to calculate maybe in a larger population, maybe it'll involve few hundreds. So that then we will make it into a more concrete studies. Yeah.
Okay, so how long is this data collection? How long? The 27 respondents.
Okay, it's supposed to be for about 4 months, particularly because it started in somewhere about end of January. It's supposed to be end of April. We're supposed to complete everything, 3 months plus. But however, during my time, I only managed to collect about 2 weeks, 2.5 weeks to 3 weeks, about that. Yeah, before it's all covered, because after that there is some restriction in the ophthalmology clinic as well, because they have some restriction of how we should go in, and then we do not want so many patients and everything. And then that's when the case started to rise, and there are certain circulars that they cancel a few appointments and everything, because we are totally depending on the participants who have attended the appointment in the ophthalmology clinic. So those are just some restrictions that we have during the pandemic situation. Yeah.
Okay, thank you. Thank you.
Thank you so much, Doctor.
Yeah.
Thank you.
Okay, thank you, judges, for the Q&A session. Okay, we have our last presenter to present to us today, which is M47, Muhammad Nazib bin Muhammad Nazori, with his presentation entitled Health Efficacy and Assertiveness Scale in Malay Language, a Validation Study.
Assalamualaikum and greetings. This is a presentation on a study involving translation and validation of health efficacy and assertiveness scale in the Malay language, presented by me, Muhammad Nazib bin Muhammad Nazori, PhD candidate in promotion in the School of Health Sciences, University of Science Malaysia. So I hope to share with you 4 things. First, what's the background of this research, why we do it, so an introduction to the research topic. Secondly, how we do it, that explains the methodology that we've used. Third, we will present to you the results of what we have found. And finally, we'll briefly list the take-home messages in the form of discussion and conclusion based on the results that we had. A bit of context to this research on 3 points. First, the modern medical practice now put emphasis on informed consent because of the principle of autonomy, principle of human rights, and we want patients now to be an active player in deciding their health. Secondly, all patients reported the need for knowledge. However, several studies reported that they differ in the amount and quality of knowledge that they need. And so much so that one study reported that patients feeling overwhelmed because of the knowledge given to them, so much so that they deviate from being an objective decision maker. So people study why this differing preference exists. in the patient. So two things that came out. First, it is the level of self-efficacy, and secondly is the level of assertiveness, because they are suggestive to explain this differing need for knowledge. So what is health efficacy or health self-efficacy? According to Bandura, it's basically the people's belief in their capabilities to produce given attainments. So it works on a belief level on the ability to do something. And this variable presents in many health theories in the modern world, such as the health belief model, the theory of planned behavior, you can see in the standard parallel path model, and as well in the newer risk perception attitudinal framework. And one research puts an example of this importance of self-efficacy in a way that self-efficacy moderated the influence of knowledge and vaccination intention. Health assertiveness is the ability of a person to communicate their needs, their wants and opinions without punishing, threatening or putting others down, and also doing it without fear of the process itself. And two studies have concluded that assertiveness is a crucial element to allow patients to engage their healthcare professionals to obtain health knowledge. Why this engagement is important? Because several studies have shown that healthcare professionals are the most trusted source of information. However, we can see in Malaysia especially, there are very few studies done from the patient's perspective involving health assertiveness. For the points above that we've discussed, our objective is to translate and validate health efficacy and assertiveness scale into the Malay language. A bit about the measurement scale. It is a 21-item questionnaire which measures two constructs, which is health efficacy and health assertiveness. It was developed in the US in 2015 to measure health efficacy and health assertiveness within the general health context. So it's not specific to certain diseases or certain health scenario. And it has a very good evidence of validity in terms of content, construct, and also concurrent validity, and a very good reliability on the Cronbach's alpha. After obtaining the permission from the original author, we started the process of back-to-back translation according to Beaton et al. 1998, which involved translation from English to Malay, synthesis, and then back translation from Malay to English, and a review from an expert committee before we went for pre-testing. After the process is done, we proceed for exploratory factor analysis, which was administered on a randomly selected mothers in 2 maternity clinics in Klinik Kesihatan and 1 in Klinik Desa, that was selected randomly within these 4 districts. We have used principal component analysis with Varimax rotation to analyze the data, and we also calculated the Cronbach's alpha. After that has been done, we proceed to confirmatory factor analysis. This time, similarly selected mothers from several clinics in Petaling, Kelang, Gombak, and Hulu Langat, and we calculated the goodness of fit test, the average variance explained, and also the composite reliability of the items. So during the translation process, we found that there were only 20 items that can be translated into Malay language. 1 item was dropped because we couldn't find any conceptual equivalent questions within the Malaysian healthcare context. So all the translators and the expert committee agreed on this decision to drop the item. And once we proceed with the translation process and back translated process, the all translation draft has been reviewed by psychologists and healthcare professionals, and we discussed and agreed on the final item to be included for pre-testing. Exploratory factor analysis revealed that items measuring health efficacy loaded onto two different constructs, which we have named management efficacy and info-seeking efficacy. All factor loadings showed satisfactory number and with acceptable alpha cronback. And all items on health assertiveness, except for two, loaded onto two different constructs as well, which we have named as assert to be informed and assert opinion. Two items, which is health assertiveness question 8 and question 9, was removed due to significant cross-loadings between two factors. From the results of EFA, we proceed to do confirmatory factor analysis using second-order measurement model, which reveals satisfactory fit indices as displayed here on the Siemens GF, CFI, the Tucker-Lewis index, and other residual measures. And specifically for health efficacy, the question number 4 was removed due to significant covariances with other items. The average variance explained was 0.48 for health efficacy, with composite reliability at 0.86. The alpha cronback for health efficacy was 0.798, which is very good. Health assertiveness, on the other hand, produced average variance explained of 0.48 and a composite reliability of 0.89, with cronback alpha at 0.76. It should be noted that the average variance explained did not quite meet the minimum requirement of 0.50. However, looking at the cronback alpha of both health efficacy and assertiveness, we feel that it is satisfactory. Based on the findings above, we postulated three things. First, there might be some cultural differences in how the items react within the Malaysian healthcare settings, because the final items in this study is not similar to the original questionnaire. Secondly, the final items showed a very good validity and reliability, so we meet the requirement of psychometric measurement. Third, due to the way the items were constructed in the general sense, so we can use the items in different health scenarios for future researches, and this will allow immediate use and as well as comparison between health scenarios.
Okay, thank you. I'm 47, Muhammad Nazir bin Muhammad Nazori for the presentation. Without further ado, I give the floor to the judges to proceed with Q&A session.
Thank you very much. Assalamualaikum, Cik Nazir. Hope you're doing well. Okay, it's an interesting study. I have several questions in place. When you send a questionnaire to the respondent, or when you ask the respondent to fill in the questionnaire, does the questionnaire in dual language or single language only? In BM only? Is in dual language?
Yes, Malay and English, for the record.
Oh, so meaning to say that if the person didn't understand the terms in BM, they can always refer to the English language.
Yes.
But does it that will make them it's hard for us to differentiate the BM and English questionnaire? Either actually they answer based on English or they actually answer in Bahasa. Will it create some bias there?
In fact, I think you have pointed a very good perspective on that, because yes,
we cannot know for sure whether they would answer, they would read the English version or the Malay version.
BM
And I
version,
guess
yeah.
yes, I guess that would be one of the limitations I would put into my study, and something that I should focus later on.
All right, thank you very much. Because one thing for sure, sometimes when I myself read a questionnaire in BM, I'm more confused rather than I read the one in English. So I'm not sure. Your respondent might have the same problem also later. Secondly, why only maternity clinic?
Okay, so it is part of a larger study on mothers on their vaccination decisions for their children in pregnancy. So that was the context of the population of the study. And this is a portion of the process of validating the person that we will use for the main study.
Okay, all right, thank you very much, Cik Nazir. Dr. Su, to you.
Yes, thank you, Dr. Miza. Good afternoon. Nazir, good afternoon. Thank you for your presentation. I have actually the same question to Dr. Miza just now. Why only a maternity clinic, right? So, so your sample size just now is around how many subjects in your study?
180.
180. So, and it involved how many clinics?
So in the validation study, we involved in total 6 clinics, 2 clinics for ESA, 4 clinics for CSA, and for in each clinic there is equal proportion of KK and KB being presented. So in ESA you have 1 KK and 1 KB. For CSA phase you have 2 KK and 2 KB.
Okay, so thank you, Nazir. So my last question is, in your opinion, to what extent would you think that this skill will give benefit to our general population?
Okay, right. So this study was constructed in the bigger umbrella of health promotion, and whereby within health promotion, there is this objective, which is to enable a person to take charge of their health. So that's the whole idea of health. And in doing so, we wanted to improve the knowledge ability of them to acquire knowledge and also to consume knowledge. And using this tool scale, you can use it as a way to determine or segregate who needs how many information and the level of quality of the information. So that's how we've taken in the questionnaire and how it can be applied in healthcare scenarios, especially in educational intervention.
Okay, thank you. Thank you.
Thank you.
Thank you, judges, for the Q&A session with our last presenter for today. And we have come to the end of our room's oral session today. Thank you to all the presenters for your participation and cooperation. Special acknowledgement goes to the panel of judges for evaluating the research presentation today. Before we end this session, may I request all the participants and judges to switch on the camera for a virtual photography session. And And I give to the PIC technical to proceed with the photography session.
Ms. Rosawani, please turn on your camera, please. Ms. Rosawani, Major Rosawani, are you there?
Dr. Razawani, can you turn on your camera for the photography session?
Sorry.
It's okay, it's okay.
We're going to take two photos. The first photos, everyone, I want to see all your smiles on the camera. And the second photos, I need everyone to show us thumbs up, okay? So let's go with proceed with the first photo. Ready, in 3, 2, 1, smile. Hold on. Okay, for the second photo, show me your thumbs up, okay? Ready, in 3, 2, 1, smile. Hold on. Okay, I think that's it. Back to you,
Okay.
MC.
Okay, thank you. Thank you, PIC, for the presentation, for the photography session, sorry. Before we leave our virtual room today, I would like to remind all the participants to join us back at 2:30 p.m. for the plenary speech by Associate Professor Dr. Maizan Mohammed, closing remarks and prize-giving ceremony. Besides, we are kindly to request all of you to fill the feedback form via the link provided in the chat box. Thank you all, and may the best one wins. Assalamualaikum warahmatullahi wabarakatuh.
Thank you so much.
Thank you. You may leave the room meeting.